Okay, so good evening, good morning, good afternoon, everybody. I bring greetings from Mohak Bariatric and Robotic Surgery Center here in India, and welcome you to the 12th episode of Virtual Bariatric University. We are all live, and today we have a discussion on a procedure, which is one of the most popular procedure, one of the most talked about procedure, and that's the one anastomosis gastric bypass or the mini gastric bypass. And we're going to discuss about the length of the biliopancreatic limb and whether does it matter or what implications it has on this procedure. Before I start, let me introduce you with our great group of faculty which we have today. I have Professor Enrique from Mexico. Enrique is a great surgeon and expert in digestive endoscopy, obesity surgery, and has 25 years of experience in this particular field. He's an active member of Mexican Association of Gastroenterology and is recognized as one of the leading doctors in digestive endoscopy in Mexico. Enrique has published and is one of the active members of MGB OAGB Club. Enrique, a warm welcome to you to this webinar. Next, we have Dr. Kamal Mahawar from UK. Kamal is a great friend and he is a very famous surgeon from Sunderland in Royal Hospital and is a visiting professor in the university. He is the safety lead for the South Tyneside and Sutherland NHS Trust and has written over 125 peer-reviewed articles. So he's one of the most prolific writers we have in the field of obesity surgery, and he almost every week or every month we have great data, great articles coming in from his desk, and we are so proud of him that his roots are from India. He's also now the associate editor of Obesity Surgery and Clinical Obesity, and we can proudly say that he's on the editorial board of prestigious SOD. He's recognized widely for his contribution to one anastomosis gastric bypass, has always been a big proponent for this procedure, and has helped this procedure grow with the data and the publications he has made. He's a council member of BOMS and chair to its patient safety committee. Also serves in the National Bariatric Registry of the BOMS and Scientific Committee of International Federation for Surgical Obesity. So Kamal, we are extremely proud of all of your achievements and you're a great friend, and we welcome you on this webinar, which is addressing some very important issues. And I think with your knowledge and your publications and your database, you can guide us in the light of that. Next, we have Dr. Nasser Sakran from Israel. Nasser is again a very, very close friend, and he comes from Israel, and he's a pioneer in minimally invasive metabolic surgery from Israel, currently the chairman of Israel Society for Metabolic and Bariatric Surgery, and also the director for Advanced Laparoscopic and Bariatric Surgery Unit in Afula, Israel at the Emek Medical Center. He's a clinical assistant professor of surgery at the Technion Israel Institute and on the executive board of the Israeli Surgical Association. Published many articles, and more noted are his articles for mini gastric bypass. Is also a member of the editorial board of obesity surgery, reviewer of SOT, and the World Journal of Surgery and Indian Journal and the Journal of Gastrointestinal Surgery. Pardon me. His practice reflects his wide experience in laparoscopic bariatric surgery, not only in MGBs but OAGBs and sleeves and CIDS and revision surgeries. Welcome, Nasser, and I think we also look forward to your meetings which you organize with Professor Shikora every year. And those are landmark meetings, and we are so proud to have you on this show. Next, we have Professor Jain Chevallier from France. Professor Chevallier is a professor of both surgery and anatomy at Université de Paris, and he's also the president-elect for the IFSO-EC, co-founder and past president of SOFFCOMM, the French part of the IFSO. And he has authored more than 200 scientific papers, editorials, textbooks, and presented and put the concept, or you can say the standardized part of the mini gastric bypass, as one of the leads during the BMSS meeting which we conducted in New Delhi. Professor Chevallier has worked a lot to bring a lot of reputation and a lot of credibility to this procedure, which is a controversial procedure, but because of his data and his surgical wisdom, I think the mini gastric bypass has seen the light of the day. So Professor Chevallier, welcome to this course. Welcome on the Virtual Bariatric University, and myself and Dr. Fobi, we are honored to have you. Let me introduce you next to one of my friends, my brother, my close colleague, who has made the country proud, Dr. Kular. And I can tell you that the credit to me starting mini gastric bypass goes to Professor Kular and Dr. Rutledge, because they were the one who were instrumental. And those were the times when I think myself, Kular, and Jammu, three of us were the only surgeons in India who were taking the flag ahead for the mini gastric bypass. And we have seen all good, bad days together. So proud to have Kuldeepak Kular on this show. And Professor Kular is a president of a huge group of hospital, the Kular Group of Hospital, based out of Bija in Punjab. And he is the founder of the World Association of Mini Gastric Bypass and the MGB OAGB Club. He was appointed its president in 2014 during the IFSO in Vienna by Professor Mervyn Dietl. And Kular has personally trained and mentored, has been mentored by Professor Rutledge, who we know that is the pioneer of this procedure and the one who has shown this procedure to the world. So Professor Kular, so proud of you. And when we see that you are leading this organization, the MGB OAGB, across the world, and not only leading it, but teaching other surgeons to do it, it gives us immense pleasure to have a countryman doing such a great job. So last but not the least, Dr. Mayank Jain. Dr. Mayank is a GI laparoscopic and bariatric surgeon based out of Agra in India. Highly experienced in laparoscopic and minimal access surgery, and he's associated with Synergy Plus Hospital as a senior consultant. And he has worked as a consultant in various capacities in different medical institutions in Jaipur and SDMH, SGPGI Lucknow, and also now in Pushpanjali Hospital, Agra. So welcome to this show. Mahak and Manoj, both of them are our junior consultants at Mohak, and they are our right and left hands doing great job here, publishing articles and working under Dr. Fobi and myself. So Mahak is a laparoscopic bariatric surgeon, and he is also associate professor of the department at the Department of Surgery at SAIMS Medical College, the managing trustee and secretary of Sri Aurobindo Institute of Medical Sciences, Indore. He has trained under Dr. Fobi and myself, and we are so proud to have him. And now he is giving us and the program a lot of support, name, and care. So Mahak, welcome. We look forward to listen to your lecture today. Manoj Reddy is a laparoscopic bariatric surgeon in India. He is also assistant professor in Department of Surgery at the SAIMS Medical College. Again, both Manoj and Mahak trained under me and Professor Fobi, and now they are the strength of this program. And most of the surgeries they perform are like, they make us proud every other day. So myself and my teacher, mentor, Professor Fobi, are the co-directors for this course. let's start this program without any delay. It's a very interesting session today. So I would like to invite Kuldeepak, Kular, Nasser, and Professor Chevallier and Dr. Jain to moderate the lecture sessions, please. Thank you.
Kular.
Yeah, good evening, everybody. I think without wasting any time, let's start with the talk.
See it now?
Yeah.
Oh, you look fantastic.
We see you.
Great.
Can share your screen now.
Okay, thank you very much. Good morning. Good morning from Mexico. Good evening in India and other parts in the world. It is a pleasure for me to be invited to this nice, interesting meeting. And my task is to talk about the outcomes with the OAGB with the 60-40% BP limb, common channel limb lengths. So for this talk, I'll do a brief introduction, then talk about the small bowel, length variations, and its measurement. The history in our view or in our center about establishing the limb lengths in OAGB. Then I will talk about the study and outcomes which led to our current OAGB with 60-40% BP limbs, common channel limb lengths, to end up with the conclusions. So as you know, OAGB is a modification of the MGB, which was introduced in 2002.
Enrique, we're not seeing your screen.
Oh, you're not?
No.
I'm sorry. Let's see. You see it now?
No.
Hmm.
Just take your time.
How about there?
Yes,
There we
yes,
go.
yes.
Yeah.
Okay.
Thank you.
Yeah.
Now you did hear, you did listen to my outline, right?
That was very clear. You can go from here.
Thank you. So as I said, OAGB is a modification of the MGB, and besides an anti-reflux mechanisms, which you all know, it includes other concepts and proposals. One of them is the complete small bowel measurement and using it as a parameter to estimate limb lengths. And this is currently considered by us an essential concept. So as far as the small bowel length variability in humans, these are the most recent studies that we have. The first one is a study by Bakheit with more than 600 live patients, laparoscopic measurement, and you can see the average and standard deviation, and then the range of that. As you can see, this is actually one that has the widest range from 250 centimeters to 1,300 centimeters. Then we have all these either with live patients and measurements done openly to other cadaveric patients or measurements. This last one by Taquino, he actually included a table where all the previous studies were included, and you can see some that are as old as 1885. And again, the ranges are really wide from a low of 201 centimeters to a high of more than 1,000 or 10 meters. So there's a great variation in small bowel in length in humans. So for this reason, we believe complete small bowel measurement is mandatory in order to use this information as a parameter to establish limb lengths. I'd say not only in OAGB, but basically in all mixed and especially hypoabsorptive procedures. Many surgeons are a little reluctant in doing this because of either logistics. I just heard Dr. Jacques Himpen say that he does not do it because he's in a training center and he's seen increased risks when fellows are doing this. So our proposal has been to do this not between the patient's legs, but from the right side of the patient, as you can see here. And we include some more trocars in order to do this triangle that you see here. In green is where the camera will be in the right mid-clavicular plane. And then we have these two 5 millimeters trocars. The surgeon's right hand would be in the right iliac fossa, which is one of the trocars that we insert just for this small bowel measurement. And the surgeon's left hand in the right subcostal mid-axillary. This is one that will be used also for the liver retractor. So we, instead of performing the small bowel measurement from between the patient's legs, we move to the right of the patient. The cameraman is above the surgeon, and this allows us to take the benefit of the inclination or the oblique direction that the root of the mesentery has from the left hypochondrium to the right iliac fossa. So to facilitate this, we lift the greater omentum, and this identifies the ligament of Treitz. For the first cases, we inserted a measuring tape for 10 centimeters, and we go counting by 10 centimeters all the way to the ileocecal bowel. Halfway, we mark the intestine at the mesentery, and then we continue measuring to the ileocecal bowel. We do take advantage of changes in the surgical table positioning so as to facilitate the small bowel counting to the ileocecal bowel. And then, as you can see here, we see the ileum, the cecum, and then after we decide based on this parameter and some others that we will talk about, we mark this site inserting a silicone drain in the mesentery, and then we will go back and retrieve this small bowel loop. This was not always the case. Actually, when the first series was presented in 205, the first 209 patients, we used fixed 200 centimeters BP limbs counted from Treitz ligaments, just as in MGB. However, due to our results, we decided to move along and started to count routinely the complete small bowel from the Treitz ligament to the ileocecal bowel, selecting a mid portion while running the small bowel, almost 250 to 350 centimeters. And then for increased BMIs, we added 10 to 50 centimeters with no specific formula, trying to always maintain at least 250 centimeters of common limb. We use other factors such as extremes of age, metabolic comorbidities, a pure metabolic surgery in BMIs, class 1 obesity, or even just overweight. And this, of course, changes our whole pattern. Now, we did this study in order to try to find the optimal limb lengths in this kind of operation. So we tried by a mathematical model to find this optimal lengths. These are the demographics and intraoperative limb lengths of this study. We started up with 350 patients, but excluded a total of 50 that were not followed up for the 5-year minimum that we had, the age, gender, body mass index, and you see here our total bowel length, a median of 506 centimeters, with ranges from 430 to 600. Now we did this, we were able to do the BPL total bowel limb ratio because we knew we know the total bowel length. So we had 55% average with plus minus 4, for this ratio, and for the common limb, total bowel limb ratio of 45 plus minus 4, as you can see there. This is the weight loss and the comorbidity remission 1 to 5 years postoperatively. This is in the first column is our baseline weight, and then as you can see, the comorbidities that were present in the group: 35% had diabetes, 43 hypertension, 37 dyslipidemia. And through the years 1, 2, and 5 in the different columns, you can see a pretty good weight loss outcomes that you can see here, and of course also a pretty good comorbidity remission in this group of patients. We established a correlation between limb lengths and weight loss, and there was, of course, a linear correlation that you can see in the green squares here for the BP limb length and the BP limb total bowel length ratio, and an inverse correlation with the same, but counting the common limb and the common limb total bowel length ratio. We then established an ideal BMI of 25 or less and performed a ROC curve analysis to find the most accurate parameter to predict an ideal BMI at either 1, 2, or 5 years, as you can see in these graphs. And then we calculated the area under the curve for all parameters, and the accuracy, which was found by the area under the curve at all intervals, found that the most accurate parameters were: number 1 was the common limb to total bowel length ratio, and number 2, the common limb length. Far behind were the other two that were involving the BP limb. Then we determined cutoff points for these two most accurate parameters. So you can see for the common limb length, a cutoff point of 220 centimeters found a sensitivity at 1, 2, and 5 years of 79, 75, and 73% respectively, and specificity of 65, 62, and 65 at 1, 2, and 5 years. Of course, if we let this cutoff point below 180, well, then the sensitivity and specificity was 100% for all these cases. But this is too low and compromises safety, of course. Then we did the same thing with the common limb total bowel length ratio, and we established first a common this parameter in a 0.43 or 43%, and you can see a sensitivity at 1, 2, and 5 at 78, 73, and 78, specificity and 69, 65, and 69. And then, of course, if we went below 37%, these parameters were 100% for this variable. Applicating these cutoff points at the 5-year follow-up, you can see that we do have a very good, the efficacy is of course better if we have applied these intervals in the first column, and it is compromised if we go over 43% and over 220 centimeters for the common limb. However, if these two measures are applied, or these two variables, you can see that the safety in regards to the nutritional deficiencies was not compromised. And this is another way of viewing these figures, as you will see from Dr. Mahawar and the other presenters, that go when they start going with BP limbs lower and lower. We did find several limitations in the study that we emphasize at the end in the discussion, and these are depicted here. So first of all, our results may not be applicable globally. This is an extremely selected group of patients. as far as ethnic, social, cultural, economic, and maybe other factors. Our strict preoperative selection process that assures patients that are very compliant and our rigorous postoperative requirements as far as eating habits and supplements for GI adaptation, as well as a strict clinical and biochemical follow-up, make this, as I said, a very select group of patients. There may be, of course, a need for even longer follow-ups. 5 years is okay, but we should go over 10 years. And of course, RCTs comparing different limb lengths in various populations are difficult, but of course, highly desirable for this very controversial issue. In conclusions, estimation of limb lengths is highly controversial, but I should say this is not only in OAGB, this is for all mixed and especially hypoabsorptive procedures. Due to human variability, in medicine, I could say that in general, 2 + 2 seldom equals 4, and this is particularly true for this topic. Complete small bowel measurement is thus, in our view, mandatory. As a chronic progressive disease, obesity tends to recur, and this calls for an aggressive therapy, of course, without compromising safety. OAGB with 60-40% BPL common limb lengths resulted in excellent outcomes in our highly selected group of patients. The common limb total bowel length ratio and common limb length were the most accurate to predict a BMI below 25 at 5 years, and the common limb total bowel length ratio of 0.4 to 0.43 and common limb of 200 to 220 centimeters are recommended for this group of patients. Of course, factors inherent to different populations must be weighed in to estimate limb lengths for best long-term results. And I thank you very much for your attention.
Kular.
Thank you very much, Professor Enrique. Very interesting presentation. And as we have seen you working and we have discussed and seen you talking many times earlier as well, your 60-40 ratio is really working well. And I think I firmly believe that the tailoring of the intestine is very important. The tailoring of the BP limb is very important. As we see different reports coming from different countries, now in mini gastric bypass or the one anastomosis gastric bypass, the main fear is not the bile reflux or the malignancy coming up in the esophagus. Now probably the main focus of fear has shifted from malignancy to malnutrition. As we see in the Y Omega trial in France as well, we have Professor Chevallier with us. He can comment on this. But I think from your data, this is very clear because you have so big series and such a vast experience, long-term data. This is very clear that tailoring of the BP limb and the longer the BP limb, the more effect you see, not only in super obese, but in every patient. Unlike if you look at the literature of Roux-en-Y studies, like Kamal has done a review, he has looked into all the data of Roux-en-Y bypasses, but the length thing was not clear in that. It has been a lot controversial. If you increase the BP limb, whether the patient loses more weight or not. But even he has found that this thing has got something to do in the super obese patients. Definitely, he has agreed in his review that in super obese patients, yes, the BP limb makes a difference. Maybe those studies, majority of them, they were having small numbers, not very long-term studies. It could be the type 2 error, in those studies. Otherwise, if you look at all the published animal studies and look at other procedures like the duodenal switch, the BPD, where we use longer lengths. So this is very clear that the procedures with the longer bypassed length of intestine definitely have a better metabolic effect. And at the same time, when we look at the short bowel syndrome, our understanding of the short bowel syndrome from general surgery, it's very clear that if you have 200 centimeters of distal ileum in hand, definitely the patient can survive with the 200 centimeters of distal ileum. But at the same time, as you have already told, that the effects are not same in every country. We need to understand, like we see our Indian scenario, the way you guys are doing these long lengths, keeping up to a common limb of up to 200 centimeters. In our series, we have not been able to go beyond 300 centimeters. I have tried longer bypasses, 300 centimeters of BP limb. So on an average, I'm talking about 400 centimeters of common limb. And that too only in selected super obese patients. Otherwise, on an average, our BP limb is now 180 centimeters. So I think the background where the patient is coming from matters a lot. What kind of diet the patient is taking. Like we see patients coming from South Africa, they can tolerate longer lengths. But I think we must agree that the BP limb matters, and probably MGB is like the same old Roux-en-Y with zero Roux limb and the full BP limb. And in the Roux-en-Y, where we had 50 centimeters of BP limb or 70 centimeters of BP limb, has not shown a similar metabolic and a strong sustainable effect like mini gastric bypass, probably because of the same reason that the BP limb in the Roux-en-Y was very small. And now we understand that Roux-en-Y was primarily a restrictive procedure. Yeah, do you have anything to say on this about different patients coming from different backgrounds? If you see some patient coming from India or UK, do you give him a shorter length or you do the same?
Well, I firmly believe this is a very important issue because both Dr. Rutledge and Dr. Carvalho have stated that this is a very powerful operation. And with this power, a great responsibility comes to all of us. So we should be very careful. I've seen, and probably it's your same experience, that malnutrition, even if it's in a low incidence, is like a big rock in your, I don't know if you have this saying in your country, it's a stone inside your shoe, you know? Well, for me, it's a big stone inside my shoe. And then weight regain on the other side, many of these patients don't even come back because they feel frustrated and no one even, cares anymore. So this balance between a very aggressive operation and maybe a not as an effective one, which would lead to weight regain, must be balanced in order to get, the greatest equation for this. So yeah, I agree. There are many factors. In fact, I can tell you that my practice here in Mexico City is a mixed one. I have a private practice and a public practice, and the patients are quite different. The economic status is different, and the protein that you can get in the private, in the types of food that people there eat, is quite different from the patients in the public. So I've probably been less aggressive in the public sector than in the private, and this only is giving you one example of the differences that I talked about.
Right. Thank you, Professor Enrique. Professor Chevallier, do you have something to comment on this? And then we move on with the next talk.
Well, I will not take too much time, but as you mentioned, what happens in France with the OAGB trial, I just want us to remember that when it was 127 Roux-en-Y compared to 128 mini bypass, which were 2 meters along BP limb, and there were 9 nutritional complications after mini bypass and none after Roux-en-Y. And so the French government decided no longer to reimburse the one anastomosis. But the principal reason of all that was political, because in France, bariatric surgery is reimbursed, and it was time for codification of new procedures, and codification of the one anastomosis had to come at that time. And because of this trial and because of too many malnutrition complications, they decided no longer to reimburse it until new trials were done. But it was a specific political reason for that.
Got it.
I have some comments, Kular.
Yes, yes, please.
Sakran, go ahead.
Yeah, please.
Enrique, thank you very much for your perfect, again, topic. But I have some comments because, you know, our small bowel, the average of our small bowel is about 7 meters. 60% of the small bowel are jejunum and 40% are ileum. What you talk about gastroileal anastomosis with common channel about 200, 220. For me, that means it's malabsorptive procedure more than mini gastric bypass. I think it's the same like SADI, because the SADI, the common channel, it's 2.5 meters, and you have an average 2.2 meter to 2.2. And I am confused. If you have gastroileal anastomosis with short bowel, that you don't have the malnutrition, all the you know, the malabsorptive complications that we have in one anastomosis or in Roux-en-Y gastric bypass. Maybe you have another data like me, but I want to hear from you why you have better results than maybe another like in Israel. Maybe our Israeli people, they have short bowel, I don't know. The second question is, you know, today, what you think about the Luca that published, I think with Kamal, with Scott, about the new procedure, SAGI, the single anastomosis gastroileal bypass. It's the same like your technique. What do you think about that?
Well, I'll start with that last one and tell you that I don't think it's the same, because SAGI does not count the total small bowel length, and you saw the variations that have been published as far as total small bowel length. So maybe take into account the patient with 350 centimeters of total small bowel length. You go and start counting from the ileocecal valve, and SAGI, as far as I remember, goes 300 centimeters. So you would be leaving a 50 centimeter BP limb, and probably that patient will have weight regain in the medium to long term. So we again stress the importance of total small bowel length measurement, and you know, the reasons that I've heard of not counting, which involve higher risks and maybe logistics in each center, I think can be overcome if you standardize the way you count, because it just takes us about 10 minutes. And we have not had any, you know, incidental high iatrogenic lesions that we did not see. Maybe one or two that we did see and just repaired, but no other problem. So we do emphasize this total small bowel length counting. This is the difference I would see in these other operations, where you do not know either the BP limb length or the common limb length, however you see it, depending on the operation. As far as outcomes, I don't know, maybe it's the very strict selection process, like I said, for having compliant patients that do follow the recommendations and the follow-up that we have, both clinical and biochemical. Maybe that's what gives these outcomes. A final thing I would like to say is that when we have had malnutrition, it's not always regarding very small common limb length. Many times it's other things. Patients that have a depression, for example, and stop taking their supplements or even stop eating. As I said, this is a very powerful operation that is very susceptible to these kinds of things. So I would say that malnutrition is not always, or there should not be always a linear correlation with increased BP limbs, not all the time. I don't know if this answers the questions, Nasser.
But Enrique, we know that the absorption of sugars, amino acids, proteins, and fatty acids all are in the jejunum. When you perform the anastomosis with the 2 meters from the ileocecal valve, how you can explain why you don't have a hypoproteinemia, hypocalcemia? I don't know. Your results are, I don't know, better than my results. Okay, I can't explain that.
Okay, you're also a digestive surgery, right?
Yeah.
So you've done small bowel resections.
Go ahead.
I perform, but you know that a small bowel less than 2 meters is short bowel. Okay, short bowel, the patient can have suffered from all the outcomes of short bowel disease.
If you keep the ileocecal valve, and there's many papers in this, if you keep the ileocecal valve, 2 meters can adapt and patients can have a normal life. And this has been proven. So this is in small bowel resections that are, you know, an acute reason, a gangrenous intestine and with illness. Doing this in a bariatric procedure where you supplement the patients, where you take care of the patients even in the preoperative state, can lead to these kind of results. I do agree that it's a very aggressive probably approach. And I can tell you that not all the OAGB surgeons, making the difference between MGB and OAGB, not all the OAGB surgeons perform this 60-40%. I can tell you myself, I do make a difference between the patients. So it's not a routine rule of thumb for each patient. We do take into account many other factors, like I said at the introduction.
Let's move on to the next. Dr. Sakran, go ahead and introduce it.
I think Kamal wants to make a quick point.
So the point is, I think that we should be cautious when extrapolating the literature on short gut syndrome to bariatric surgery. The reason being, those patients normally have a full-sized normal stomach and their calorie intake is not reduced. Whereas when we talk about gastric bypass patients, these patients do not have a normal full-size stomach and their calorie intake is significantly reduced. So we cannot extrapolate the short bowel literature to bariatric surgery context. That was the point I was trying to make. Thank you.
Good.
Great point.
Excellent point. Sakran, go on with the next speaker, please.
Yeah, thank you. It's my honor now to introduce Dr. Bhandari Mahak. He will talk about the analysis of the weight loss pattern after OAGB based on severity of obesity in patients with 5 years follow-up. Mahak?
Did you join?
Yeah. Where is Mahak?
Okay, we can start with Kamal's lecture first, and then we can have Mahak.
Shall I unmute myself and share my screen?
Please.
Yes. Okay, we can see, Kamal, your screen is...
You can. Well, thank
yes,
you very
yes,
much. I'm
beautiful.
just going to somehow also see a different mode so I can see the pictures. Okay, just give me 1 second. I want to...
Your screen is visible. Go ahead.
Okay, great. So, well, thank you once again, Mel and Mohit, for giving me the opportunity to talk about one anastomosis gastric bypass and limb length. So I'm trying to just go to the last slide, and I can't. Okay. This is a topic very close to my heart, and I think I've presented on this in different fora as well. So with apologies, I start because some of this you may have heard before. So let's go back to the beginning of gastric bypass. Gastric bypass, as we know, was conceived by Mason in 1960s, and we need to know what Mason performed. The first gastric bypass that Mason performed in the world, my apologies, the patient's BP limb length was 24 inches, approximately 60 centimeters. And then obviously Mason published his first series of 24 patients in 1969. And in that series, in those patients, Mason does not mention the exact limb length, but he does say a short loop retrocolic gastric bypass was performed with very good results. And he noted that 12 patients who were studied for 1 year or more lost an average 96 pounds. So reasonably good weight loss, as you can see, with his short limb retrocolic gastric bypass. And then the concept of Roux-en-Y gastric bypass came in. And when the first Roux-en-Y gastric bypass were described in the literature, the elementary limb was approximately 30 centimeters. The only reason for this was basically to remove the bile reflux, which was being seen with Mason's gastric bypass. That's how the Roux-en-Y gastric bypass was born. But from there, over the last roughly 3 to 4 decades, somehow we started saying the gastric bypass is a combined restrictive and malabsorptive operation. And that meant that the operation, which was actually a gastric bypass, became a gastric and small bowel bypass. And this led to gradual increase in limb lengths. People were trialing even dangerous limb lengths. Dr. Kular very kindly alluded to that review that we published 5-6 years ago. And we found all kinds of things were happening in the world. But did that lead to improved weight loss or comorbidity outcomes? I'm not entirely sure. But then, because most of those studies were bypassing longer limbs as Roux limb, and because there was a Roux limb, even those who used longer BP limb, I think it was relatively safe. It got unnoticed. And obviously, when OAGB came, and it doesn't have an A limb, and also because this procedure also had multiple other points of controversies, this point became very, very, very clear, and people started noticing this. OAGB was initially introduced, and I think Dr. Kular confirmed that point as well, that it decreased the restriction of Roux-en-Y gastric bypass and increased the malabsorption, making it a balanced procedure. And I'm about to share some data, some theories, which would hopefully suggest that it is not a restrictive malabsorptive procedure. It's a gastric bypass. We don't fully know how a gastric bypass works, but we're beginning to understand that. So what is the danger? The danger is that if we do not adjust the OAGB limb length appropriately or correctly, then this operation will become like a BPD. And I don't need to remind OAGB surgeons of what happened to the BPD, right? That is the danger. That is where we are. And that is why my personal bias has always been, this was published some 4 or 5 years ago, that OAGB is a gastric bypass. We must treat it like gastric bypass. We must take it towards a gastric bypass if it is not there, because that is how it will survive. We know that when in the gastric bypass context, when you have a Roux limb with a similar BP limb, a Roux limb of 50 centimeter added, this is an elegant study by Himpens and colleagues. Interposition of a Roux limb decreases the metabolic effect of the operation, decreases the incretin effect. That is crucial to understand, that when you have a Roux limb, it has multiple advantages. It is a great idea for reflux control, but it decreases the metabolic effectiveness of the operation. Sorry about that. In terms of the mechanism of action of one anastomosis gastric bypass, we don't really have a lot of physiological data because this procedure has been controversial. So scientists around the world don't really take interest into this. There have been some very good studies from Professor Chevallier's group, but then that's it really. There's this study from, I think, Eastern Europe, which showed that there was similar endocrine metabolic effects between MGB and OAGB procedures. What I'm trying to say is that when I say that OAGB is a gastric bypass, there is some scientific basis to that, and more will come in future. But Michel Garnier is right in saying that this operation can behave like a BPD, because it does behave like a BPD. We have to remember here the historical literature. Rutledge published his first paper where I think he described 180 centimeter BPL, because there's some discrepancy between the text and the figure. So I've gone with the 180 centimeters. And in that paper, with all the constraints of the follow-up that we are aware of, Dr. Rutledge reported 1% excessive weight loss, requiring what he called gastroplasty. Now, we know that that is a variation of reversal. Similarly, Lee was using a tailored plan for his patients, and he reported a similar rate of malnutrition as well. So it is not that malnutrition is an invented problem after this operation. I go around the world, and I've been hearing this from colleagues around the world, that OAGB is associated with nutritional issues, and what are we going to do about that? Then the Omega trial. Professor Chevallier mentioned about this. OAGB is not inferior in terms of weight loss, but higher incidence of diarrhea, steatorrhea, and nutritional events were associated with a 200 centimeter BPL. I'll remind you here, I was one of the reviewers of this paper. Initially, the authors had said just OAGB. I made them write in the conclusion 200 centimeter BPL OAGB, because this is the difference here, and that needs to be understood. And what happens when we use longer limb lengths? Patients die. And that is why I am passionate about this. Not some ego trip for me, or something that I'm really passionate about. Professor Chevallier has been saying this for 4 or 5 years, and he's a pioneer in the field. And I've really taken on his cue and have developed the idea that he propounded, to be honest. It is his idea. Patients die when we use longer limb lengths, and that is no good thing. We did a survey study, and I know the weaknesses of surveys before you point that out to me. But sometimes survey is the only data to tell surgeons what is happening. Hundreds of surgeons from around the world using different limb lengths. And what we saw, very clearly we saw, that only when you use more than 200 centimeter BPL limb lengths that you see malnutrition and patients dying. Surgeons who were using 150 centimeters, they didn't see this problem. And that is why we expounded, we hypothesized that an OAGB with more than 150 centimeters BPL is ill-advised, and one should not perform it. But then at the time, there was not much data on how effective this would be, and would this actually not compromise the efficacy of the procedure. As it turns out, it wouldn't. I've been given 10 minutes. I don't want to take you through each study that I've got here on the slides, but obviously, there are papers out there. You can read themselves, or you can ask me and I can send you the papers. Paper from Ahuja and Tatia, and people know from India that Tatia is a respected surgeon in the country. They wouldn't just say things if they, if they didn't actually believe in it. Authors say, and I quote them, a 150 centimeter BPL is adequate with very minimal complication and good results. In their study, the patient they were tailoring, so the patients were not similar at the baseline. It's important to understand that. Liagre et al., 8-year results with 150 centimeters. Similarly, efficacious procedure. You can see excess weight loss of 84.8%, target total weight loss of 35% nearly, not bad at all. Pizza et al., 150 centimeters, safe and effective. This is Khalaj et al., 160 centimeters, safe, and actually better than 200 centimeters in terms of nutritional issues. We have published our own data comparing 200 to 150 centimeters, hardly any difference in weight loss. And there are other surgeons as well. So generally what we can say is that when you use longer limb lengths, you increase the nutritional complications without significantly increasing the weight loss benefits. Then you'd argue, why would you actually want to increase the limb length? Why would you actually want to use the longest possible and not the shortest possible limb length? Is malabsorption a necessity for gastric bypass procedures? And we have seen that even in the short term, and I'm talking about Roux-en-Y gastric bypass, because Roux-en-Y gastric bypass is a gastric bypass, as is OAGB. Malabsorption is not, it happens because you can't do some of these operations without a degree of malabsorption, but it's not required. it accounts for very little calorie deficit in the short term and probably nothing in the long term. Variations in measurement. When we talk about any length that we are proposing or recommending, surgeons need to know that small bowel is not a rigid tube. The concept of fixed length, rigid lengths, do not apply to a collapsible organ like small bowel, which will be measured differently in the same patient by same surgeon on the same day even. So whatever we recommend, it should be able to absorb the variations in measurement. I don't call it error because it's a variation, it's no error. So to conclude, ladies and gentlemen, I know that many surgeons are looking at the longest safe limb length or even the ratios that my friend Dr. Enrique Luque-de-LeOn is proposing. My personal bias is that I'm looking for the shortest safe BP limb length, and I think sometimes less is more. And I think we can even take it down further from OAGB 150, because I think, you know, when we're doing Roux-en-Y gastric bypass, for decades, we have shown that a BP limb of 50 to 100 centimeters is very effective. And that is when we also have a Roux limb. So without the Roux limb, I think even a 100 centimeters OAGB would be effective, but that needs to be studied. We're going to develop those studies. I'm talking to colleagues around the world about that already, and work is in progress, I can assure you. And I don't think we will see much difference in terms of outcomes, but we will improve the safety in terms of protein calorie malnutrition. And more importantly, we don't even discuss this, the micronutrient malabsorption and malnutrition. With that, and with the thoughts that I believe the ideal BP limb with OAGB is 150 centimeters or less, I would conclude my talk. Thank you very much. I'll stop sharing now. I think I've been stopped sharing.
Dr. Jain with us. Mayank?
Yes, Mahak is here. Mahak, start with your lecture.
Yeah.
Next किसका होगा?
Mahak,
Yeah.
you can start.
Yes. Thank you for this opportunity.
Yeah.
So I'll be presenting on the analysis of weight loss pattern after OAGB on severity of obesity in patient with 5-year follow-up. So I bring greetings from my medical college, the medical school, and the super specialty hospital. Below is the super specialty hospital known as Mohak Bariatrics, where I work. So I have nothing to disclose, but Dr. Mohit Bhandari is a consultant to J&J, Medtronics, Bariatric Solution, Stryker and Apollo, and Dr. Fobi is the chief for Bariatric Corporation. So this is our case mixed disclosure. We do a variety of procedures, but mainly we are doing the sleeve gastrectomy, the gastric bypass, and the OAGBs, in which we do a banded as well as non-banded procedures. And now we have started with ESGs also. It can be conventional as robotic. So as an introduction, in recent years, MGB is being performed in increasing numbers because it is technically easy to perform. And it is currently the third most common bariatric operation performed worldwide. And MGB is a modification of the loop bypass described by Mason in 1967. And it was introduced by Dr. Rutledge in 1997 as a simple bariatric procedure, alternative to Roux-en-Y gastric bypass. So my objective was to determine the weight loss pattern of OAGB in different class of obesity and the significance. The basic intention for me for choosing this topic was to just know that in our series, in between 2011 to 2013, we used to take the BP limb at 200 to 250 centimeters. So right now, after learning, we have reduced the BP limb, but this data is from 2011 to 2013, in which the BP limb was 200 to 250. So the method, the data was on 414 patients who underwent OAGB from 2011 to 2013 at Mohak Bariatrics and Robotics, were prospectively maintained, and data on the severity of obesity and weight loss was analyzed and presented. So this shows the WHO classification in which there is class 1, class 2, and class 3 obesity of BMI 30 to 34.5 and 35 to 40. 40 to 50 as class 3 obesity, and above 50 as super obese. So the baseline characteristics, as you can see, the total number was 414, and we chose for in class 1 there were 30 patients, in class 2 57 patients, class 3 obese 203 patients, and class super obese it was 124 patients. So the mean weight was 96, 107, 123, 146, and the BMI was also 33, 38, 44, and 54.4 respectively. You can see the p-value also. And so as far as comorbidities are concerned, these obese people in my series, as you can just see that in the class 1 and class 2 obese patients, the difference is that they have got more diabetes percentage. It goes up to 73.3%. And in the super obese and the class 3 obesity, it is 40.3 and 33.8 respectively. This is in my series at my hospital. And the other comorbidities like the OSA, which is very significant in class 1 and class 2, again, it was 63 and 85.9, class 3, 84.7, and class 4, it was 92.7%. The other parameters like the hypertension, the cardiovascular parameters, asthma, back pain, joint pains, it stands at a lower level, but it was around equal in all the obesity classes. And the follow-up, so we did a 5-year follow-up, and the follow-up rate, as you can see, that at 6 months it was 99%, at 1 year it was 91.3%, 2 years it was 83%, and at 5 years it was 60.6%. So the excess body weight loss after undergoing the OAGB was, I have highlighted at the 3-year, as you can see that in the class 3 and the super obese patient, they went up to 82.68. They went down to 82.6 and 81.5. And after that, they started regaining weight. But in the class 1 and class 2 obese people, as you can see that they were still losing weight. So this, I wanted to show that in the class 1 and class 2 obese people using a BPL of 250 centimeters, they tend to lose more weight and they were still losing the weight. So this graphical presentation, as you can see from the arrow, that at the 36 months, you can see that all were doing very well, but the class 3 and the super obese people, they were started gaining the weight, but in the class 1 and class 2, they were still losing the weight. So the excess body weight loss more than 100% was seen in class 1 and class 2 obese people. That's why I was saying that offering an MGB to class 1, class 2 obese people with a BP limb of 250 centimeters, as you can see that they were losing much amount of weight. It is around 30.76% and 33% respectively. And in the class 3, it was 2.38 and super obese, it was 0.86. So the resolution comorbidities, yes, MGB is a very good procedure. I do accept. But as you can see that all were doing very well. Basically the diabetes and the dyslipidemia, it was very well resolved by doing an MGB. So as you can see in the class 1, class 2, class 3 obese people, all were losing, the diabetes were cured in all the around 70% diabetes remission was there. And dyslipidemia also, it was more than 50%. So it is a good, you can see resolution by doing an MGB. So this is a very important slide. So as far as nutritional deficiencies are concerned, as you can see in the class 1 and class 2 obesity people, the hemoglobin, the anemia was seen in more than 20% of the people. But in the super obese and class 3, it was around 12% only. Then talking about protein deficiency, it is a very significant value that it was more than 40% in class 1 obese people. And it was around 32% in the super obese and the class 3 obese people. The calcium deficiency was more seen in class 2 obese people. That's why this class 1 and class 2 obese people have got more nutritional deficiencies. So what we can discuss is that remission was diabetes was very good, as the paper by the Cabajo and Bruzzi with longer BP limbs, but the nutritional deficiencies were observed in our series are more in low BMI people, especially in class 1 and class 2 patients. And again, more than 100% of excess body weight loss was seen in class 1, class 2 obese patient with 30.76 and 33%. And resolution of sleep apnea was also significant. So what we can conclude is that OSA increases with increase in weight, and class 1 and class 2 patients keep losing weight beyond 3 years with 1/3 of, with 33% of more than 100% of excess body weight loss. This procedure is very good for class 3 and super obese patients because they have got a good weight maintenance from 3rd to 5th year. Because rather than losing weight, it should be just a minor increase in weight, doesn't make any difference. And a shorter BP length should be considered in the patient with class 1 and class 2 obese patients, because there is a discussion about OAGBs with what BP limb to be taken. So in this particular presentation, I just wanted to focus on what we were doing previously in our years, that we used to take the BP limb of 250 centimeters, but now we have made a rule to keep the BP limb at around 180 centimeters. And in some people in which we find the glycosylated hemoglobin more than 8.5. So according to the Mohak protocol, if the BMI is around less than 32.5, we do take the BP limb of 150 centimeters only. But still there is a need for multi-center and prospective studies to correlate our findings. So thank you everyone. Thank you for this opportunity.
Thank you, Mohak. Really, thank you for sharing your research. It's, I think, a great job, and I think that you have really a lot of patients there. But again, we talk about the biliopancreatic limb length, and you know, the IFSO we had before 1 year together. I think all of our colleagues here was there in Hamburg, and one of the points that was the length of the BP length, at least it's about more than 80% said that the length must be 150 to 200. Okay, I can't agree with my friend Kamal that it's more, maybe less than maybe 100. It's enough. We will see, and it will be interesting. But the problem is that some surgeons perform more than 2 meters. Okay, the problem with that, it's not for weight loss. The problem is that the patients can suffer from the malnutrition. It's clearly, I think, for the, you can make 2 meters, 3 meters, 4 meters, it will be the same for the patients. The problem that the patient can suffer from the, you know, the hypocalcemia, hypoproteinemia, hypoalbuminemia, etc., etc. And I agree with you that for BMI 40, it's 150, it's enough. Between 40 to 50, it's 2 meters, but or for redo 2 meters, but not more. This is my opinion, and this is the IFSO opinion. Okay, that's I think that was close, and I hope that we can, or my colleagues here that can agree with me that more than 2 meters, it's not a good option for our patient. I want to hear my colleague Kamal that he want to have new research about that. What do you think, Kamal?
With regards to 100 centimeters, Nasser, the hypothesis is that a BP limb of 50 to 100 centimeters has been sufficient for, you know, I would say millions of patients with Roux-en-Y gastric bypass. It was sufficient in the loop configuration for tens of thousands of patients who had Mason's loop gastric bypass, because he was using a short retrocolic limb, which is approximately 50 to 60 centimeters. So I just cannot understand why for all other gastric bypasses, for Mason's loop gastric bypass, for Roux-en-Y gastric bypass, a BP limb of 50 to 100 gives you long-term, durable, effective weight loss. That why would it not be sufficient for OAGB? And I know it is a hypothesis at the moment in OAGB's context, but again, I think it is a reasonable hypothesis because editors have given me the leeway to publish that, otherwise they wouldn't do. And I think we need to study it. I'm not saying that I know the future. I'm saying we need to study it. And we are, as you know, developing a multi-center international cohort study to look at that, and time will tell. My hypothesis is that you'll be pleasantly surprised and we'll be able to take the limb length down without compromising the efficacy of this procedure.
Let's do this. this has been a nice presentation. And for sake of time, we would have a case presented, and then we would follow with a panel discussion, and we would cover all the topics. It's been very interesting so far. So do I have the fellow there who is going to introduce the patient? While you're getting them, I'll just make a comment. I'm very impressed with the extent of weight loss in the 3 presentations, 80% plus. I mean, we have a very strong procedure. I am beginning to wonder whether we're dealing with peptic ulcer disease, which in 1970, me and my colleagues were dealing with truncal vagotomy, parietal cell vagotomy, selective vagotomy, and the problem was completely something else. Is it possible that the lymph length is not the problem? As I watch these operations, and you're going to see in a minute, making the size of the pouch. I see so much variation in the size of the pouch of the OAGB. And I see so much variations in the anastomosis. And then there's variation in the size of the patients. Are we really looking at the right thing? With that, I'll go on to the live surgery, and then we'll discuss as a panel thereafter. Are we ready? Shashank? To Kular, make a comment. We have people watching. We have almost 500 people.
Thank you, Dr. Fobi. I was looking at your centers data, and probably, you know, when we have everything in hand now, on one side we have Enrique presented his long-term data. Now we have your data, and I have my data in hand, and look at different publications. I think what Kamal is saying, it makes some sense. We need to have the minimal optimal length which we should be using. We don't want to have the maximal optimal length, but definitely we will have to tailor. Like even we are also using 100 centimeter for the low BMI patients now as a study, you know, process, and we'll be publishing this maybe jointly with Kamal in the coming times. I think now we are in the operation theater, so Dr. Fobi, please take over. Please continue.
Okay, Shashank, go ahead. Present the patient, please. Oh, Dr. Matu.
Hi, good evening, everyone. We are live from the operating room, and I'll be giving the case details of the patient. The patient is a 45-year-old male and with a weight of 130 kgs with a BMI of 45. He's a non-vegetarian and he has OSA, and he's a diabetic patient on insulin. The patient's HbA1c is 7.6 with the B12 and protein and albumin all in the normal limits. So the patient underwent a COVID test, RT-PCR, which was negative. So now I'll be giving the mic to Dr. Mohit Bhandari, who will be demonstrating the case.
Hi, good evening, everybody. So as all of you know, we always start with an intraoperative endoscopy. And this is something which myself and Professor Fobi, we always address, because this practice is actually different from what surgeons do across the world. We do all our endoscopies only intraoperatively. So the decision which surgery has to be done is taken intraoperatively based on our algorithm. So I'll just start with the endoscopy first to demonstrate you the findings of endoscopy. So basically what we want to see in the endoscopy is the length of the esophagus, the gastroesophageal junction, if there is any ulcer inside the stomach or active gastritis. And then, you know, once we see all these things, we try to see the hiatus. So as you can see here, this is the Z line here. The Z line is exactly at 42 centimeters. This patient has a little bit of height. I don't see any esophagitis here. It looks okay to me. Then when I go inside, I search for gastritis. We go close to the pylorus here. And also because this procedure would involve removal of the duodenum, it is important for us to just assess if we have a duodenal ulcer. So I'm gonna go here and As you can see, we are into the duodenum. Now, when I am here, I would just try to search for any pathology in the duodenum, and when I pull my scope back, I can see that the duodenum looks perfectly normal. I don't have an ulcer or a polyp which I am missing onto. So that's pretty important when we do all these endoscopies, that we are not missing on pathologies, and then later on we have to have problems. While we come back, I always look at the hiatus here. So you can see we don't have a problem with the hiatus. It's nice. And there's a little bit of fluid in the fundus, which we're going to evacuate once we put the gastric calibration tube. I can do a part of this evacuation by my endoscope itself. So that this is taken care of. Now we'll start with the procedure. So first, my port position, just the external view. So as you can see, I have one port which is just supraumbilical. There are two 12 mm ports, each on the side of my port which is supraumbilical. They are in the anterior axillary line on the left and the right side. They are both 12 mm ports. So these are the plastic ports which we can throw. And this is the reusable 10 mm optical port. We have two 5 mm ports, both in the right and the left subcostal area, 2 finger breadths below here, as you can see, and both of them are in the anterior axillary line. We have a 3 mm liver retractor, which is non-scarring. So this is the assembly which we have, and I'm standing on the right side of the patient. Can I have my specs, please? So I stand on the right side of the patient, and my assistant stands between the legs of the patient. And I have one more assistant who is on the left side of the patient. Now the first step, as you can see, would be to open the lesser sac. And the landmark to use the energy source on this particular area would be just opposite the incisura. So that's the incisura. And I just try and be close to the stomach and try and open this area. Now, as you can see that sometimes we have a lot of fat in this area, which can make the entry difficult. But at most times, we have a very easy entry into the lesser sac. You can see the posterior wall of the stomach. And also you can see that the pancreas is visualized very beautifully. So once we have done this, we would take the first load, which is fired from the right side 12 mm port. And this load, I do different. So I see Professor Kular and others doing in a very different fashion. But what we basically do here is we fire this particular load here from the right side rather than the epigastric port. Some surgeons put an epigastric port and they fire the first reload from the epigastric port. And everybody can have different port position. This is just what we feel conveniently doing. There's no harm in using an epigastric port, and that's also good. That's also safe. But it's okay. I mean, you can use, we feel more comfortable in using this particular port, so we do it. Using the epigastric port, we have to use a 4 centimeter of a cartridge instead of 6. That's more head-on with the this area. Now, the second important step is that once we start to do all these firings, we should be very sure that we are not obstructing the remnant, which drains this particular pouch. So we always, sort of see the area visually that it does not obstruct. So I have done 2 firings. The first one was the gold. The second one is a blue. And you see all my firings, if it is visualized in the PIP. When just show the PIP of my port, just focus here. Okay, so you can see all these firings are done from the focus close here. They are done from the right side port, and I am also standing on the right side. And this port is a 12 mm reusable, disposable port, of plastic port of 12 mm. And this particular firing is done from this particular port for the complete pouch which we have to make. We are using a 38 French bougie. Although this bougie is a very rough estimate of what sort of pouch size we would keep. Usually the pouch is around a length of 15 to 18 centimeters. I'll measure it for you, and the breadth is around 2 centimeters to 2.5 centimeters. So that's the routine which we follow. So when we have these articulating instruments, the advantage is that we can, articulate the stapler gun and use the 12 mm port on the right side. And, we need not have these problems, these beautiful articulation, which nowadays we have with the disposables. Gives us more freedom, I would say, in terms of doing all this stapling. Now, as you can see, I've reached the area of the short gastric. So my technique would be to avoid a lot of dissection in this area and do a minimal dissection and maybe blunt dissection mostly. So you can see that without any problem, I have sort of reached that area close to the lesser curvature, close to the short gastrics, and not too much of a dissection done, using a lot of energy source. So most dissection is being done by, and I always follow this step, I do most of this dissection by my blunt of my stapling device, my gun, I mean to say. So that being said, you have a nice area here, you can see where this gap is there, and I can easily put in my stapler gun through that. I use a blunt grasper to dissect that area, and it works very well. I have, even in super obese patients, we have been able to find that space without using too much of harmonic in that area. So that's it. This completes my pouch. I'm going to measure the length and the breadth for you just to demonstrate how it looks. This is the G junction here. So you can see this is starting from there. This is around 10 here. Let's take, so and another, so this is 18 centimeters of a pouch, as you can see. If we see the breadth is uniform around 2.5 centimeters, 2 to 2.5 centimeters. So it's 2 here, 2.5, 2.5. So on an average between 2 to 2.5 would be the, is what we usually follow. There's some oozing, and we usually keep a gauze. Most times this oozing stops automatically once we come back after the anastomosis. If there's a spurter, yes, obviously we need to take care of the oozing. Now, this particular fat, which is there posterior to the wall of the stomach, I usually dissect all this fat because I feel that it makes the stapler height non-uniform. We are supposed to fire a blue here, but if you keep all this fat, a gold looks to me more popular, but more feasible. But because we are using the small bowel, and the gold for a small bowel would be a bit too much, so I always remove this fat so that we get a good understanding of what length we are firing. Because for a stomach pouch here at this level, a blue is good only if we do not have fat on the pouch. So you can see the bougie is there. I have made a nice gastrotomy. And now, very important step about what calculations we do in terms of the limb lengths. A lot of discussion around that. The point here is that we don't calculate the common bowel length. We don't go to the IC junction and do that, because I feel there's first, my reasons for not doing it is that there's a high chance of injuring the bowel, number one. Number two, we are very conservative with our limb length. So you can see that there are some adhesions there, but this is the ligament of Trides, and that's the continuity. So I'm going to count it from here. So that's 10, 20. So this grasper has the marking done. You can see that the marking on the grasper 20.
Himanshu, the PIP is
30.
obliterating the surgery. Good.
40, 50, 60, 70, 80, 90, 100, 110, 120, 130, 140, 150, 160, 170, and 180. So that's the limb length, and we standardized after Professor Fobi came. We sat and we saw our data, and we standardized this this BMI to 180. So what we realized later on, that now we have to probably go into dive deep into our data and see if 180 centimeters is a bit too less for BMIs more than 50. That's what Dr. Fobi will discuss, but this is the point as of now. What we did as a practice in Mohak, we did 180 centimeters as a standard for everybody, and we used an objective method of calculation, that's the grasper marking. I do not calculate the common channel. When we count 180, we do not go to the IC junction like Enrique has shown. I feel that number one, there's a high chance of injury to the bowel. Number two, what I realized of late is that, as we were discussing, Nasser was not very satisfied with what Enrique said. He said that how can two patients have very different incidence of deficiencies? What I believe is that there is a reason to it, why two set of patients can have different results out of the same procedure. The reason is that we know that the bowel is different from being 4 meters to around 10 to 12 meters in different individuals. So that's first variation which we are talking about. The second variation is the cells of the intestinal villi. So we have the intestinal villi which have different densities in different individuals. So I went through the literature, and I saw that there's a 30% variation in the density of intestinal villi and the crypts of Lieberkühn across the small bowel. The third and the most important variation which we are trying to discuss is about the sodium glucose transporters, which are very different in different individuals. And the fourth and the most important is the protein transporters. So the handling of the proteins, the handling of sodium, the handling of chlorides are very different in different set of populations, and depends upon so many variables that, that's why everybody here is talking correct, but they have so much of variations in the data, because we are talking about two entirely different absorptive mechanisms, and that's the problem which we are facing. So the point is that when we have people from different ethnicities with different sort of variations, we have to be governed by our own data. So if for example, Dr. Kular knows that his database is showing that the kind of patients he is operating are doing pretty good with even the BPL of 300 centimeters with common channel of 350 centimeters. So it's his data which is showing him or guiding him the path of his practice. I cannot go and generalize that data to my patient, because I may be having some more findings. And when we perform cases over 4,000 mini gastric bypasses like we did, we are bound to go ahead and get guided by our own findings rather than listening to what somebody else says. And that's what we are doing. Myself and Professor Fobi, we realized 180 centimeter is very good for patients with BMI less than 45. But the moment you go with a BMI more than 45, there is weight regain. Then these patients have problems with weight regain, because either the bowel adopts very fast, or maybe 180 centimeters is not too good for malabsorption for patients with a BMI above 45. So we are not trying to modify our own algorithm in the light of our own data. Similarly, we realize that when we go with limb lengths more than 180 centimeters in patients with BMI less than 45, our complications were high in terms of nutrition. So what I mean to say is we have full right to discuss about why there is a variation, but we cannot question somebody's data, because at the end of the day, it's what their practice is. It's what they have been seeing throughout their practice. And that's why what you see and what you feel, as a surgeon, you have more conviction in doing it, and also ethically correct. So I was expecting this difference between what Enrique feels and what Nasser feels, and that's why we're here to sort of discuss this point. But I think it stems from the fact that we are talking about too many variables in terms of intestinal absorptive capacity, in terms of handling of multiple channels, proteins, carbohydrates, fats, fatty acids. So that's why these variations. So the procedure is complete. I will ask my anesthetist to bring in a bougie now. The length of my anastomosis would be somewhere around 4.5 centimeters. We fired a 6, but because we do some burying of mucosa and serosa, it reduces in capacity. So this is Dr. Dikshit, who is coming in with the bougie, and that's passed. We would always pass it across the efferent limb. So that's the afferent limb of 180 centimeters, and that's our efferent, that's the bougie. So thank you very much. If there are any questions, I would answer.
Well, we'll probably go for comments. Go ahead.
Yeah. First of all, it's a very nice technique, Mohit, really. I think we have the same length of the pouch. Pouch, it must be very, very long, okay? Like all our friends today talk that when you make very long pouch, we don't see the bile reflux, and I agree with you. But I have some comments. From 3 years till now, I use only white cartridge for the upper part of the stomach and for the anastomosis, and I don't see bleeding. What do you think? Because I see that you use blue cartridge and gold cartridge. If you think that to have white cartridge for the anastomosis, maybe you have less bleeding.
Yeah. So frankly, I never used a white cartridge on the stomach. In my entire life, I have done some 5,000 sleeves. We have never used a white on the stomach, around 4,000 gastric bypass and 5,000 mini gastric bypass. Never used a white on the stomach. I never remember that. So I think I don't have the experience to answer your questions. Maybe Kamal or Enrique, who would have used white. I think blue is good enough for the stomach. We were initially using the blue for the first firing also in the mini bypass, but I feel that area which is just below the incisura is a little thicker. So I use a gold there, which is I'm very happy using a gold. A green bleeds a little more. The gold is good enough. And then all the blue. So Nasir, I never used white on the stomach.
Okay.
So I have no idea. I have no experience. I think white, and also it depends if in India we have a little thick stomach. So I'm scared. I don't know. Kamal, have you used white on the stomach anytime? Kamal or Enrique or maybe?
No, we use purple from Tri-Staple from Medtronic. And for the anastomosis, we either use a tan from Tri-Staple or a blue.
I use tan from Medtronic and white. Okay, because we published before 3 years our sleeve that the last 3 fire was white, and we published that we'd had less complications like bleeding. I think the companies that they said to us you must be careful. It is like you said, you think that the stomach is very thin. It's okay for you that you use blue or gold cartridge, but I said it's okay. It's my opinion. I use white or tan for the upper part of the stomach. I don't see no leakage and I don't see no bleeding. Okay, I will publish this data, I hope, in the next year. But it's we can talk about that. Before 15 years, I think we make the anastomosis between the gastrojejunum with green cartridge. After that, we start with blue cartridge, and now we make it with white or with tan. That's mean that also we surgeon, we can have our opinion with your experience. You see the thickness, you do everything, and you think for you it's okay blue, but that's the reason that you talk that you see some bleeding sometimes.
Can I say something here?
Yeah.
Yeah, Mohit, a very, very good surgery you have done. Really very impressive. Congratulations. First of all, the endoscopy which you are doing, I love this. And now we have also started doing this on table because, this is very, very comfortable for the patient when patient is under anesthesia. So if you try to do it before surgery, majority of the patients don't want to undergo this procedure of endoscopy. Number two, about the cartridge size, about the white, blue. Let me tell you frankly, see the main challenge with this long line is the bleeding now. It's not the leak. We know the commonest complication. And I don't know, Mohit, how frequently you see a significant bleed if we talk out of 100 patients. I think in our data, we have like three to four patients out of 100 who would have a severe, significant bleeding where you either have to transfuse or sometimes even you might have to go in the evening and do a relook. So out of that fear, I even tried the white cartridges as well, and we also tried the purple one. I talked to these company people also. The problem is these cartridges are not perfect thing. The way we do suturing with our hand, that never bleeds later on. But the cartridges, after some time, like Mohit said, the thickness of the stomach varies. So if you have not used the appropriate length, even if it was very small, in the evening, you still can see bleeding. We have seen this bleeding with the white cartridge as well, and it has not come to zero actually. So I wish these companies could start making cartridges with altogether different mechanism, like the swing machine kind of mechanism, where you have a reel at the back. It's a kind of thread, and the cartridge would keep on cutting, and then it will, suture like a sewing machine. Unlike these fixed length, cartridges. So otherwise, my experience has been that you will still see some bleeding because we are dealing with different livers also. We need to, see these patients have fatty liver, NASH, many of them are alcoholics also. So their coagulation in many patients are, disturbed. So keeping in view this long line, we have to monitor them closely, and we need to understand that the cartridges which we have in hand as of today are not perfect. Yes, Mohit, what's your experience about your bleeding incidents?
Yeah, so we have, as you said, we have bleeding, but it's not 3%. We have a 0.01% of incidence in mini bypass. And one of the reasons why is we are very aggressive with application of clips. Now, very aggressive. Now, can I show you, can you put the screen view inside? Can I have the view of the screen? I just wanted to demonstrate something to Professor Kular. Can you see my line? Just focus on the line. Now you see how I put my clips. Can you see?
Yes. So many clips you have.
There are so many clips. So, our fellows and,
See,
Abhishek and all those who work with us, they are very particular. So we take good time in doing hemostasis. Now, if you can see here, even, small places. So now, and the way I apply the clip is absolutely, if you see at the base. So what I wanted to communicate as a message that the assistant can hold this line here with the Maryland and then go absolutely snug to the base. Put it.
See, Mohit, this is very important. Like Mohit finished the case, but what they're doing now, this is the most important thing, because if you are not doing this, you will definitely see 3 to 4% incidence of severe bleeding. The line looks totally dry. When Mohit was doing it, it was totally dry. But you see, by the evening, you might even see 2 liters of blood inside the peritoneal cavity if you have not done this. So what we are doing now is we are overswing, especially in this COVID era. We don't want to bring in the same patient again in the evening.
Absolutely.
So in the COVID era, we have not seen a bleeding because we have been suturing with a V-lock. I put 2 lines on either side, and that takes a little time. I'm a little bit scared about the clips. Your team has to be really very well trained. Like Mohit, you have your guys with you, but if it's every other time you have a new person in the operation theater and putting a clip there, this can be a little bit, sometimes you can do some trauma, and you can see some leak with the clips. That's why we are against using the clips and the energy sources here. But definitely the way you guys are applying the clip, it's actually parallel to the line. And you have seen in your practice, it's very safe. But I must emphasize that these cartridges are not perfect, and maybe they need to change the mechanism, the way these guns are working, because why we should be using the clips, or why we should be suturing over the staple line. If that has to be done, probably the day is not far off when, Mohit, you finish this in 14 minutes. And why can't you do it without staples? You can take another 10 minutes and we can do it without staples. And there's no, then there will be no bleeding at all. So then the day is not far off when you will see staple-less, mini gastric bypass coming up. And we have done few cases. We will be publishing that. And we are very much comfortable with that because it doesn't bleed. But I think the companies will not be comfortable. Maybe they need to improvise upon this thing. Otherwise, our surgeon brothers, because now they have got so good hands, and with every 10 years we have the new generation coming in. Like now we have
Professor
Kular,
Kular, we're going to move on.
This is going to be,
I would like to have the other experts
Yes, sir.
weigh in on the significance of lymph length. Bleeding and hemostasis is going to be a topic, but today we're going to concentrate. I would like to have Kamal Chevalier weigh in on this topic of lymph length. Let's hear what you have to say. Looking at what Mohit does, he does 180 centimeters. What do you have to say about the length versus the pouch he makes and the anastomosis? It's Kamal, you have any comments?
Yeah, I mean, Mal, we've discussed this before, and I think your Mark wanted to say something, but I think 180 centimeters is an effective operation. My only thought there was that obviously it's a great operation Mohit did. That his pouch seemed a little bit bigger than what I would do. I stay quite snug to 32 French orogastric tube, and the capacity seemed a bit wider to me. And I wonder if that is the cause of some weight regain that you're noticing. Having said that, I don't have any 5-year data on our cohort, so I don't know that, and I can't talk to you about that with any degree of confidence. It remains to be seen if limb length is an important factor in weight regain. We know from Indian data that was published with Baig et al. That OAGB showed least weight regain compared to Roux-en-Y gastric bypass and sleeve gastrectomy. But the vast majority of those patients would have been performed with an OAGB of 200 centimeters or more. So with shorter limb length, will we see more weight regain? I think the comparative data needs to be seen. And perhaps because you do all the limb lengths, maybe you could do that comparative analysis, 5-year outcomes with different limb lengths. And it would be interesting. Thank you.
Yeah, I think, Kamal, you made a great point about pouch size. A 32 French bougie is a little too, I agree that's very tight kind of a pouch. The same which we talk about a Fobi pouch. So this would be a long Fobi pouch, which we used to make for bands. I don't make that. What I thought was that if we make very, very small, very restrictive pouch, that probably, created some problems. So we are a little liberal on the pouch. You are correct that this might be the cause of the weight regain. And yes, we have to follow that. And that's why, as I said, that with our 5 years data, we feel that if this technique is what we practice, BMI more than 45, Professor Fobi says we need to increase our limb length, what our data is showing. But yes, I will reflect on the fact that the pouch size can be further reduced, and maybe we...
But even before reflecting more, we could do an elegant study there, because your pouch size has stayed the same, whereas your limb lengths have changed.
Yeah, that's what I'm saying. So we can do that study.
Just compare the long-term outcomes and see if the weight regain is any more in 180 centimeters or less, as you believe it to be.
True.
And then you'll know the answer. But no, I think, thank you. Great point.
True.
We have that. I'll give you Jain to talk, but we have that data. That's what Reddy was going to talk about. But I think it's just 3 years, and at 3 years, both are doing very well. We have to wait and give you a 5-year presentation. Jean-Marc, please.
Just say weight regain after mini bypass is quite rare, but in our experience, most of the time it's the restrictive part which no longer works. There is a dilatation of this pouch. So I think it's very important to have a a long and narrow gastric tube like Mohit showed us. Restriction, even if it's a more malabsorptive surgery, in our experience, when it failed, it's always because of the restrictive part, dilatation of the tube.
I agree with you again, because the pouch, I think, first of all, I think that Mohit make the procedure like the consensus of IFSO about 180 centimeters. Great, I think it's good for this patient. And I saw that he standardized the technique. This is what we need to do, to standardize our technique. Okay, I performed the same. Long, it's about 18 centimeters tight. I don't believe that, you know, this procedure only malabsorptive. It must be also restrictive procedure. What he did, I think this is the perfect, or what you say, the perfect procedure, long, tight, long and tight pouch, 150 to 200 biliopancreatic lymph, and this is great. Okay, that I agree with all of you. And again, about weight regain, I really agree with Chevallier that we see that the surgeons that leave a huge or big, you know, big pouch, or they leave a little fundus, that we see after 5 or 10 years that this patient, they start with weight regain, and the problem is with the restriction, not with the malabsorption here.
True, absolutely.
Can I comment on the operation?
Go ahead.
Congratulations on a swift, very nice operation, Mohit. This is a classic MGB, as Dr. Rutledge has taught. And there are, of course, a lot of differences with the OAGB. First of all, the intraoperative endoscopy is really nice. And the problem with us is the logistics, both in the public and private practice, at least here in Mexico. But this is really nice. Now you start at the pouch, as MGB teaches. We start at the small bowel counting. This is all done from the right side of the patient. The supramesocolic, you do from the right side of the patient. We do between the patient's legs. And the vertical stapling, as many of the others have said, is not close to the calibrating tube. We do a very narrow 36 French, and standing between the patient's legs, I think, is easier to have a very straight vertical stapling. When you do it from the right, you do kind of a different, configuration, and actually you may be using more cartridges than what you would do if you do a very straight line. They're talking about pouch widening as a problem with weight regain. I would also add maybe the larger incidence of marginal ulcers, which, as you know, the pathophysiology of them is acid. So a greater pouch maybe it leads to a larger incidence of marginal ulcer. The blind dissection in the upper part of the pouch is another difference. We, as you may have seen in our videos, do an explicit dissection of the fat pad in order to, we believe that it's better to confirm that the staples are stapling the stomach and not the fat in this part. And we have not had any leaks at this part of the pouch. Of course, the small bowel counting is a big difference. I do like the marking, the 10 centimeter marking. This is really nice. But as you know, we continue all the way to the ileocecal valve. Our anastomosis is, of course, wider than the Roux-en-Y, but not as wide as yours or even Dr. Rutledge, which he says 6 centimeters. We go 2.5 to most, to 3 at the most. And of course, the anti-reflux procedure that, or mechanisms that you all know. Now, you mentioned something that is really nice, and the variation in intestinal villi and glucose, or the transporters, sodium, glucose, and protein transporters. You cannot measure that preoperatively or intraoperatively, of course. The only thing you can measure is the length. So I ask each of you, I understand that you pose as an argument the larger risk of, or the increase of risk of injuries. Do you have any other explanation? I'd like to hear. I'm very fond of Dr. Mahawar's work, and I'd like to hear his thoughts on why not counting the whole small bowel. This is something we can do, and it takes. I know you guys are, maybe very swift in this kind of operations. It took Mohit 14 or 15 minutes. Maybe 10 minutes of small bowel counting is too much for him, but we think is time that is well invested, and this will probably lead to more knowledge in this bariatric operation.
I agree, Enrique. I think, no, that's not, we can devote 10 minutes to this procedure of counting the entire bowel length. I have not done that in, at least 5,000 mini gastric bypasses I've performed. And I think I'll reflect upon what you said. In fact, myself and Professor Fobi, both of us, we were discussing about it. I'm always open to learn. I would definitely think about doing that. And once we start to measure all the limb lengths, you're very correct. Maybe we can come up with a study, and we never know. Maybe the limb lengths of different ethnicities and different countries are different. I agree.
Can I say something here, Mohit?
Yeah.
I have tried to measure the length in about 1,000 patients, and after that, I left that. The reason is, if we are using up to 250 centimeters of BP limb, and if you look at the literature, in our study, the minimum which we came across was 400 centimeters. Out of the 1,000, only one patient had 400 centimeters, but the average was 700 centimeters. So if we are doing a 250 centimeters bypass, then in 999 patients out of 1,000, you will be correct. I mean, it will be more than 450 centimeters, which you are leaving behind on the common limb side. But for the OAGB, like Enrique has well said, when you are dealing with longer lengths, I must emphasize here that OAGB, as introduced by Professor Carbajo and as demonstrated by Enrique, it typically has 60-40 ratio. They are dealing with a very long BP limb. And that's why we need to understand in Indian system now, we are kind of mixing OAGB with MGB. OAGB is a different entity, MGB is a different entity. Although we are brothers, we are a group because it's a single anastomosis gastric bypass. But if you're doing a long bypass, then yes, then Enrique is right. We need to measure whole of the length. But up to 250 centimeters, I think it will not be fruitful, even if you are spending 10 minutes, but still you will come across maybe 1 or 2 patients out of 100 where you can injure the intestine. So that's why we stopped counting this. Yes.
Okay.
You may recall the paper from Iran, the fatal outcome, where in the necropsy they found that the total small bowel was, I think, a little over 3 meters. And if I remember well, they had bypassed 200 meters or so. So I'm not just talking about doing a more effective operation as far as longer BP limbs, but also in these very seldom cases with short total small bowel length, preventing this from happening.
Yeah, there's a small point, sorry. There's another thing, which we need to emphasize when a patient comes back to you with diarrhea, and all the times, maybe malnutrition as well. All the times we focus on the length. Maybe this length was too much. As you said, yes, this could be too much, but with MGB, we need to understand that there are other factors as well. You have a long blind loop. So we must also look into, there might be Clostridium difficile, which is, acting behind the bacterial infection. So these patients can be, tried with antibiotics, because sometimes you see malnutrition coming up in the 10th year, after 10th year of the surgery. Majority of the cases, after 2 years, these patients adapt. The intestine starts adapting. Looking at the general surgical literature, we know that the distal intestine has got much better adaptive capacity as compared to the proximal intestine. And I am of a firm belief that in the long run, what works better is the continued restriction in the MGB, because the pouch is not dilating much. We have been doing contrast studies in these patients, and because of the wide outlet, the pouch is not dilating much as compared to my sleep patients. Only 10 to 15% dilatation in the pouch, which comes up to 2 years. And after that, these patients don't dilate much. So there is a continued, restriction. And I have seen 300 centimeters patients, still they will also adapt over a long period. They again start absorbing the fat. So yes, the length matters. In super obese patients, I would go in for a longer length, definitely. But my opinion is that we should choose the minimal optimal length rather than going it for, very, long length. And definitely there is some reason in ethnicity, like Mohit had said. We see patients coming from different countries, and definitely there is something behind it, because you guys are not seeing much of malnutrition even with the 200, 300 centimeters of common limb. But if we have to do it in India, believe me, the malnutrition will be, way high. So there are other reasons. Yes.
Yeah, I just like to point out that I agree. You should always take into consideration afferent loop syndrome when you have diarrhea and malnutrition. And we always treat these patients prior. And also we've performed, as you said, upper GI series many years after the operation, and we have not seen dilatation.
Yes,
as Dr. Rutledge says, we have a restrictive, non-obstructive pouch, which leads to no dilatation, as may be seen in the sleeve with the obstructive nature of the pylorus.
Yeah, this is a functional restriction. Yes.
Well, we're coming to the end of the program. I think as an old man who has seen a lot of surgery, I've learned a bit. There have been a few statements that have been made, which we should take into consideration. I think what Enrique says is, if we want to be scientific, we should measure the small bowel completely. If we're going to talk about bowel lengths, we should know what we're talking about. If you don't measure it, you don't know what you talk about. So let's take that into consideration. I think if we're going to be dealing with bowel lengths, we have to measure it and then study it, and then we can make recommendations. Number two, until the time when we do that, I think what Dr. Kamal said is very important. Let's find the least bypass limb of small bowel that will give us about the same effect with minimal complications. And finally, based on the presentations we have today, we have an operation that's very strong. And it's even better from what I've seen today than the results from the BPD. My friend Scopinaro, to whom I have been paying tribute all month, his report showed mostly 70 to 75% excess weight loss. If you look at all the three presentations today, from 150 centimeter BPL limb to 60-40, we talk about 80% weight loss at 5 years. There is something else that is making this surgery more effective. And I don't think it's all the bowel length. Thank you, Sakran from Israel, Kular from Punjab, Kamal from UK, Enrique from Mexico, and Dr. Bhandari, as usual, an excellent job operating. I'll let you make your final thanks, and then we'll call it quits. Go ahead.
Yeah, so thank you, everybody. I think it's very important. Enrique has sort of given me, you may say, an inspiration to maybe conduct a study where I count the bowel length. I would admit that This is one skill set of counting the entire bowel length, specifically in super obese patients, is something I want to do in a very fantastic way. In the last webinar, we were doing a procedure which was a sleeve with a JI bypass, and it was quite tough for me to calculate the common channel. And I realized that to start from the cecum, it's not easy. So Enrique's technique of doing it, position of the cameraman and the technique is fantastic, and I would try and learn and would try and do some research, as I can do that with such a high volumes I'm operating. Number one. Number two, as Professor Fobi said, that this data is very, very important. And till the time we publish it, let's try to do minimal harm to our patients and stick to what Kamal is saying, a good optimal length with the best results which we are getting, so that a good procedure does not fall into a disrepute because of politics. Thank you very much, everybody, for coming on this show and for teaching me and teaching all other surgeons. We are really humbled to have you. Merry Christmas and a Happy New Year to all of you.